thing. And I think it's amazing that you thought of something like this and taken an initiative. I'm sure people would have taught before, but we don't want to discredit anyone who has taught anything to people before. But I think what is important is that trying to compress everything in 20 minutes is something good. And I think people can't really, watch or listen at least to somebody like me for 1 hour. So better it is to listen in 20 minutes and sort of go home. So thank you, Dr. Shilpa, for that. And I think today's topic is something which is important, which is double stimulation in IVF. And I think what is very important is this is an important topic for you should you not wanting to do the egg donation program. Okay. So if you are someone who is pro egg donation, then these type of stimulation protocols are not going to help you as far as your standard procedures are concerned. But if in case you are wanting to do self-cycle stimulation, and I'm sure the demand for that in India is going to go up like crazy over the next 2 to 3 years, then this is the protocol which people should be understanding and following. Right, Dr. Shilpa, if you want to add something to that.
No, I think more and more IVF cycles are becoming individualized, and in this era of individualized medical practice, I think we should individualize each patient and give them the best of the care. And as we all know, each oocyte will increase the live birth rate for that patient. So having that one extra oocyte by stimulation makes a lot of difference, especially with the current situation of ART rules and regulations, as Dr. Jay mentioned about the donor oocyte programs and all. So this stimulation is going to help many of you to do self cycles and also to get that one extra oocyte, which will improve the live birth rate for that patient and also for your center. Yeah, you can go ahead.
Okay, so I just want to mention one important thing about dual stimulation. So as I draw the whiteboard, people will understand this much better. But remember, it doesn't really matter in dual stimulation if you started the stimulation in follicular phase or in luteal phase. Okay, and I'm going to explain that to you in a little while as we move on. But just remember, what is dual stimulation is you are trying to compress 2 stimulations in an interval of 30 days. I think that is a better definition for dual stimulation rather than stating follicular phase and luteal phase stimulation. Okay, so I'm going to be proving that in a little while. A lot of people have also stated that there is no great role of dual stimulation. You can just wait for the next menses to come in and it is equally fine. So dual stimulation as such offers no such great advantage, but then that is their way of looking at it. So I will start sharing the whiteboard and I will just see if I'm visible on the whiteboard. Dr. Shilpa,
yes,
visible,
yes.
right?
Yeah.
Okay, fine. So what we are going to discuss today is something good, which is dual stim. Okay, this is something which I really like to do and I do a lot of it. Okay, but we will just take a standard dual stim protocol approach here. Okay, so let's assume a patient has come to you on day 2 or 3 of the menses. And day 2, 3 of the menses, this is the protocol, 3 indications predominantly. One is poor responders. Okay, very good, it works in them. Second is age more than 38, it works beautifully in them. AMH of less than 1 works beautifully in them. Oncofertility works beautifully in them. And patient who wants to do oocyte banking, okay, with low AMH. So in all these situations, the dual stim protocol will work excellently well. In the day 2, day 3, we already know that for a patient, let's assume they have a particular size of the cohort. And just one small rule which people should remember, that when you are doing dual stimulation, it is going to be an antagonist only protocol. Okay, there is no role of adding agonist protocol in a dual stimulation. So once you have added your standard HMGs, okay, we normally would add, let's assume 300 international unit of HMG for 6 days, following which the follicles would grow to approximately 9 to 12 millimeter in size. That is when you are going to be adding your antagonist shot. So then it is going to be 3 shots or 4 shots of antagonist in 0.25, okay, along with obviously the HMG, which is going to continue, okay, 300 international units. That's when the patient comes back to you, and you will have these large, beautifully well stimulated follicles. Okay, so let's assume you have 4 here. The trigger in this situation, when you are wanting to do a dual stimulation, should be your GnRH agonist trigger. Okay, so this GnRH agonist trigger, once you finish the oocyte pickup, okay, after the trigger, this will try to induce luteolysis inside these follicles. Okay, so let's assume your OPU has egg pickup has happened on day 15 of the cycle. You can start the second stimulation. Okay, you can start the second stimulation of this patient anytime from day 18 to day 21. Okay, now we normally wait till this day, we normally wait till day 21, because we want to inform the patient on the day 21 as to how many day 5 embryos we froze. Okay, but remember, you can even start it earlier. If you are doing day 3 embryo freezing, you can start it on day 19 as well. You can start it on day 18 as well. It is completely your choice. When this patient comes to you, you are going to have a picture inside the ovary, which is going to appear like this. And this is a picture which a lot of people get confused. You are going to have some abnormal corpus luteum degenerating, about to degenerate, and simultaneously you are going to have these small follicles. Okay. Actually, the recent logic which has been mentioned is that let's assume you are doing an follicular phase stimulation. So this is a follicular phase stimulation here, which is happening. Okay, it should not be written as FSH. I will just write it down as a follicular phase stimulation. So this is your follicular stimulation. People have tried to argue that when you give a GnRH agonist trigger, it is going to cause luteolysis. And because it causes luteolysis, even when you start treatment for the patient on day 21, it is still going to be a follicular stimulation only. It is not going to be a luteal stimulation. Okay, and which is actually correct. This theory is actually correct, which is why I mentioned starting this on day 2 or day 3 is not compulsory. Even if the patient has come to you on, let's say, primarily on day 21 with a low AMH, and you see an actual corpus luteum. Okay, in that time, when you see an actual corpus luteum, what you have actually begun is a true luteal phase stimulation. Okay, we'll have a session on the true luteal phase stimulation as well in the coming days, but you've begun a true luteal phase stimulation. But this follicle stimulation which you begin, it could be a follicular phase stimulation as well. So again, the protocol remains the same for your 6 days. Now you can add 75 international units more, HMG 75 international units for 6 days. And what you are going to see is a picture like this. You will have some follicle here, which would have become an corpus luteum, which is about to degenerate, and then you will have some follicles like this. Okay, so these are the guys who are in that phase of degeneration. These are that small follicles which have then grown and become up to 9 to 12 millimeter in size. Once they've become 9 to 12 millimeter in size, again you are going to go ahead and add these patients on 4 days of antag. So you are going to add antagonist for 4 days, 0.25, following which the follicles would reach a size of approximately 19 to 20 millimeter. And again, you are going to give them a GnRH agonist trigger and carry out your oocyte pickup. Okay, so you will have 2 oocyte pickup. This is oocyte pickup number 2, and this is your oocyte pickup number 1. So you are going to have a total of 2 oocyte pickups in a window of approximately 28 days. And this is your dual stimulation. In fact, as soon as you give a GnRH agonist, you can do a triple stimulation also. No, why should you stop at dual stimulation only? You can do a triple stimulation as well, and that is a triple stimulation which is done very, very commonly by us in a lot of patients. Okay, because again, this GnRH agonist is going to go and it is going to cause the same picture of causing luteolysis again. So you can again do a stimulation which you can cause as a triple stimulation. The most important point which you should understand is these type of stimulations are only possible when you are having something, when you have a strategy of no matter what happens, you are going to freeze all. Okay. You are going to get some excellent blastocyst embryos in these type of stimulations, and you are going to get a good number. So what is our target? Our target is to have at least 2 grade 4 AA embryos, which are blastocyst embryos, which are frozen. The minute we get 2 grade 4 AA blastocyst embryos, we don't do the rest of the stimulation. So let's say you get it in the dual, you don't do the triple. Let's say you don't get it in the dual, you will do the triple. Okay. And all these stimulations are actually very good because it saves the time for the patient. So if you mentally try to study the behavioral aspect of the patient in this type of situations, you are going to understand that whenever the patient goes through these type of things, after the first stimulation, you are going to tell them, "Arey, embryo nahi bana, no embryo formed." Okay. And if you call them after 15 days, they may be little shaky. Okay. Here your counseling is very simple. Your counseling is straightforward. You are going to do 2 stimulations no matter what. We will inform you how many blastocyst embryos form at the end of first stimulation, but there is a possibility that you may not form a single blastocyst embryo, irrespective of which you are going to be doing the second stimulation. Correct? And that is a very important counseling of double stimulation. A lot of times people do counsel, especially people who don't do these protocols. Are why something like this was done? It is not recommended. Okay, no such thing is recommended. So the good thing is, in fact, we have fantastic videos of double stimulation for patient education on YouTube, which is where we get more than 100% of our patients who come to us for this. So it is a very difficult opinion to challenge because patient goes through those videos which have been posted almost 2-3 years back. Okay. And patient realizes that these guys are doing this for a very long period of time, and patient is mentally okay to do the treatment. The only situation where we would not do a double stimulation to the patient is where in the first stimulation itself, she has formed 2 blastocyst embryos. So in that type of situation, we will not ask her to do the second stimulation because 2 blastocyst embryos, which are expanded, are good enough for the patient as far as carrying forward a pregnancy is concerned and going ahead with an embryo transfer is concerned. Okay. There is no role of giving luteal phase support in this entire situation. Okay, because it is a freeze all cycle, so don't even ask a question on that. But there is just one thing additional which we do. So a lot of people are worried that, array, you are doing this type of stimulation, too much estrogen is there, this is there, that is there. So we give letrozole from the first day of stimulation till the end of second stimulation. Okay, there is no stopping letrozole 2.5. It is to be taken daily. It doesn't really affect anything. It doesn't really affect the outcomes. Okay, it doesn't really do anything. Okay, it gives beautiful levels of estradiol, very low levels of estradiol, absolutely safe for the patient. It induces very quick luteolysis in the corpus luteum. You can see the resultant next follicles very nicely. And it will really help you if you add letrozole to all your HMGs when you are planning for dual or triple stimulation. Okay. This is something which really looks into the wave theory, that every day some or the other follicles are present inside the ovary which are getting recruited. Okay, and you just have to catch them at that point in time. Correct? Which is exactly the basis for doing a random start protocol as well. As a result of which I mentioned, after your egg pickup is done, you can probably wait for 2 to 3 days and immediately start stimulation. If you're freezing day 3 embryos, you can start the stimulation on the 3rd day of the pickup. If you're freezing day 5 embryos like us, you can wait till the 5th day and start the stimulation. It is absolutely okay. A lot of times people will ask, what are the hormones which you will consider before you start the second stimulation? Try considering these hormones. You will have estrogen, which is going to be approximately 400, 200, 300. Try considering progesterone. It is going to be approximately 25 to 35. It doesn't really matter. That progesterone is going to act like that meprate, in that PPOS protocol. It will prevent any form of LH surge, even if that surge wants to occur. Okay. So don't worry about it. You really don't really have to wonder, how do I get the progesterone down? Then shall I start stimulation? All these type of things. Don't really wonder. Okay. Just start the stimulation. You will get an outcome. One practical point. Let's assume your primary stimulation was approximately 9 days of stimulation, your second stimulation will be 2 days more. Okay, your second stimulation could be approximately 11 to 12 days. So just keep that much in mind. Okay, and apart from that, there is nothing else which you need to keep in mind in dual stimulation, because the trigger is standardized. It is always GnRH agonist. Gonadotropin is standardized. It is always HMG plus letrozole. Okay, there is no third thing. Antagonist is standardized. It is antagonist. Okay, there is nothing which states that you are supposed to give antagonist in between the two stimulations. No need. Okay, no such thing is needed. You want to give, you can give one shot to cause more luteolysis, but start giving letrozole, it will cause luteolysis any which ways. So you don't even have to waste money on that luteolysis. Okay, so with this much, I finished the presentation of the basic understanding of the dual stim protocol. And if there are 2 or 3 questions, we can answer, but the rest of the questions we'll answer on WhatsApp.
Okay. So you tell me, I mean, do you counsel them for PGTA for all dual stims?
It's not mandatory, but then these days when people at this level who are doing dual stimulations, if you try to speak to them, some of them want to do it, some of them don't want to do it. You should give them the choice. I would want to give them the choice. I have never done a study which tells which stimulation causes better euploid embryos and all these things as per some research papers. I don't have that type of time and energy, but people can do those studies and can find out. But according to me, as long as the embryo is formed, put that embryo inside that uterus, because these people hardly will form oocytes, hardly will have embryos. So why waste these embryos in doing PGTA is what I think. Okay.
And so do you give pre-treatment with estrogen, progesterone, ocipil, or anti-ag before the first stimulation in dual stim?
I most of the time start it off randomly, so I don't give it.
Okay. And have you noticed any cancellations in luteal phase stimulations?
Yes, some cancellations, 2 to 3, maybe 3%, 2 to 3% cancellations would occur. It will occur. That is because that particular recruitment was very less. Only 2 follicles were recruited in that particular day when you started the stimulation. It is nothing to do with your stimulation, honestly. It is just that the recruitment on that day was very less, nothing else.
Okay, so have you noticed that after the first stimulation, you said that you give a break of 3 to 5 days or 2 to 5 days. So if you start a little early, does the number of days of gonadotropins, will it increase, or it's the same whether you start it on day 2, day 3, day 4, day 5?
It's the same.
Okay, so what I have observed in my dual stims are like the initial recruitment to reach the 10 millimeter or 11 millimeter, it takes a longer time. Like as you said, 2 to 3 days. So have you noticed that it is age dependent or more of AMH dependent, or it is?
It is that second stim dependent. It is just dependent on that second stim. Honestly, one thing I'll tell you: when you do a triple stimulation, okay, it becomes just like the first stimulation. The reason is everything which is present, you have aspirated it out. Okay. See, when you go and aspirate the follicles, what typically happens is you will aspirate the follicles which are completely black, I mean completely proper, and you will also go and aspirate some of those luteal follicles, of the previous cycle. Then, because letrozole is being continued, that ovary is like a small ovary, okay? And then it goes back to the primary stimulation. So in that triple stimulation, it is as good as the primary stimulation, but in dual stimulation, yes, it can add around 2 to 3 days. There is no doubt in that.
So in even in triple stimulation, the endometrium and the ovary is out of sync, isn't it? I mean, you can never
totally out of sync.
Yeah.
There is first line I mentioned is you have to do freeze all. You cannot do a fresh transfer with these type of things.
So E2 monitoring and all, I don't think it is mandatory.
I am giving letrozole. I am mandatorily giving letrozole. So there is no E2 monitoring.
So success rate in comparison to conventional.
Conventional success rates of IVF in low AMH, when you are looking at take-home baby rates, are less than 20%. Global data, Indian data can be 80%, 90%, whatever. But the global data is at 20%. And with dual stimulation, also the data is at 20% only. Okay.
Yeah. So have you?
Yeah, Bendre sir, you want to ask something? Anil, Dr. Anil Bendre, he's a very nice gynecologist in Ahmednagar. You want to ask something, Bendre sir?
Yeah. I wanted to know why are you using letrozole, and how much is the dose which we are using for
2 point,
continuous?
as we discussed, as we discussed in the previous sessions, it is just 2.5 mg to be given, and it allows you to cause very good luteolysis at the end of oocyte aspiration. No OHSS. It reduces the risk of OHSS drastically. Okay, the same principle is followed in oncofertility as well. You don't want estrogen to spike, so you continuously give letrozole.
Continuously from day one, and it will be
From day one
till
till you finish your final pickup. 5 days after that also.
Okay. And how does it cause luteolysis? That what is the mechanism? And I didn't understand that.
So what happens is, once you have aspirated the follicles, okay, and when you continue, when you continue to give any form of letrozole, it causes severe reduction in LH pulsatility, even if the corpus luteum wants to stimulate it. So for the first few days itself, okay, there is no growth of the corpus luteum which occurs in that situation.
Okay.
Yeah.
Very good. So we have got a vast experience in doing dual steam. So how are the results as compared to the single steam or the?
Bendre sir, you know my data, right?
Are you really happy with? Yeah, I know that. I know your data, but
yeah, so I'm happy. I'm very happy.
I'm sorry. How many dual steams you do in a month, roughly?
Should be between 40 to 60 patients every month. Should be more only, but between 40 to 60 easily.
Acceptance is
because Jay is already doing more than 250 cycles. I think more than
no.
40 to 50 is 40 to 50 is okay.
No, nothing like that, Bendre sir. But yeah, between 40 to 60 patients at least every month, and yeah, I mean, patient acceptance is very good. See, by the time they come to me because they want a self cycle. Please try and understand this. Okay, almost everybody, at least in the state of Maharashtra, knows that I don't do the donor program. Yeah. I mean, the total donor program I must be doing is maybe 5 cases in an entire year. Okay, and that too because of ovarian failure or something. So most of the people already are aware, at least in Maharashtra, that if you want self cycle, then you may try your luck out with him, and that is how most of these people would come in, and they are readily accepting to do double stimulation. There is no problem.
Yeah, I think that's about it. We'll answer the rest of the questions. You need to get back to the OT, I suppose. It was quite good. It was excellent, actually. I think not many people are aware of dual stims and how it is done. So, sorry, this one I forgot. You usually start only on day 2, or do you call them
Random.
Okay.
Yeah. But see, Bendre sir is answering because he knows it.
But you give one dose of
antagonist. Yeah. See, when I'm doing a random start protocol, I will give pre-treatment antagonist, right? Because I want the cohort to be synchronized, like how we took the session on pre-treatment antagonist. Correct. When I'm doing a follicular phase stimulation, genuinely the patient has come on day 2, day 3. There is probably no requirement to give a pre-treatment antagonist unless there is an asynchronous cohort, even for dual stimulation. Okay. If needed, you give a pre-treatment antagonist, just close your eyes and give it. Don't think about what effect it will have on the euploidy status of the embryo after the 10th stimulation. Forget that. No paper has proven that a pre-treatment GnRH antagonist has a negative effect. Okay. All papers have proven that it has some effect on synchronization. So why not use it? Okay, that is my theory. And for a practical purpose situation, as I have mentioned many times, I'm mentioning again, I like to standardize things because I do not like to have a person coming onto my head and telling me that, array, last time we gave 225, should we give 300 this time? Wrong. If it is a dual stimulation, first stimulation is 300, second stimulation is 375. Finished. Okay. Third stimulation, if it is done simultaneously, it is 375. It is not 450. But then this is straightforward. there is even my junior most nurse will know it in the first week of work. Okay, that this is how it is to be done. There is no question marks, or there is no 150 units of dose which we give in IVF. That is for sure. So one has to standardize. See, if you are doing a lot of work, and if you want the work to scale up, then you have to standardize. If you want to get confused, then you have to individualize. If you really want your staff to be perpetually confused what dose to give to whom to when, then you have to follow like an individual protocol, and people will be in trouble.
Yeah. Okay. I think that was excellent basics, and I think it was very, very good to learn about dual stims. Not many people practice dual stims. I hope everybody understands the concept and also try to inculcate this into their practice to have more of self cycles. So thank you very much.
Yeah, I think even Bendre sir is there. Bendre sir, even that patient who delivered with you was somebody who had never formed embryos, right? And we did a double stimulation and she had excellent embryos. So I think even Bendre sir has had hands-on experience of the live deliveries following these type of stimulations. I don't know if sir is still around, but it is common. So there is oh, he's on mute. So I don't know. I can't even see you. So would Bendre sir want to? I don't know. Let me find him. Where has he gone? He's on mute. He said, "Yeah, I'll unmute you, Bendre sir. If you can share that experience, because I remember that couple delivered with you, and we had.
Am I audible now?
Yeah, you are audible, sir.
Yeah. The patient you referred to me for delivery was very happy actually, and she already have had 2 or 3 cycles done now somewhere else, and
No
I
embryos
think she was a case of she was treated by dual stim only, and in the very first cycle she got pregnancy. I think on the second transfer she got pregnancy.
Yeah, second transfer she was pregnant. Correct.
She was very happy. Yeah.
So it helps. I mean, what I meant to say is not because Bendre sir is my friend. What I want to say is that it is a protocol which helps people, and people do become pregnant with self cycle. So there is no harm in doing it.